Uh, I was asked to speak on role of echo in heart failure, and I'm in the habit of making some crisp topics. So since it started off with M mode, so I said from M mode to strain, let's see how did it help us in a heart failure. And you know, I will not go into that. It is the leading cause of death in developed world and second leading in developing countries. And you know the reason: aging of population and people are living longer after myocardial infarction due to better treatment options. So that, and according to WHO estimate, in next decade or two, more than 75 to 80% beds of any cardiac or medical units will be occupied by patients with heart failure. So you can imagine it's a tremendous burden on society, both in terms of manpower and finances. So it's very important not only to prevent its occurrence, but also to slow its progression. Now, what is progression? Progression reflects the underlying process of LV remodeling, which results in a decreasing ejection fraction, worsening of cardiac function, and increased risk of lethal ventricular arrhythmia and sudden cardiac death. So, what should be our aim? The aim should be to prevent
ले उसको ले आओ, उसको बोल जरा प्रेशर
the aim
पंप
should
पर
be
चेक कर
to
रहे हैं.
prevent the क्या हो गया progression of asymptomatic LV dysfunction to symptomatic heart failure. So that means we need to individualize treatment, and echo is an excellent tool for that. And before, as I've always been taking, we take a good history and physical examination of the patient. And what does echo do? It tells us about cardiac size, condition of valves, and phenotyping. Is it diastolic, systolic, and above all, it guides us in making an appropriate prescription for the patient and also predict prognosis. Now, how do we diagnose asymptomatic LV function? We see role of systolic function easy by 2D and M mode, and for diastolic dysfunction, we will have to go in little detail. Now, I started off from M mode. You have seen high five presentation. I'm a poor person working for the poor, so I put little color. This is me. In 1992, from Japan, we went to Hawaii, and Dr. Shahbaz Qureshi, this is your Dr. Sakamoto. He's a world authority on the aortic valve, and again, my professor, two other, and myself. And from this M mode, when I then proceeded to Mayo Clinic, here you can see Dr. Tajik, his wife, and unfortunately, I came to know Dr. Kanderia has passed away. Dr. Suhail, this pretty lady in pink is Dr. Kanderia's wife, and in the door picture, I'm with Dr. James Stewart. Okay, so this is from M mode to that. Now, for diastolic dysfunction or function, it is very important to, I've always been talking about pathophysiology of the disease, and you have to see that what are the peak filling rates determined by? It's determined by rate of myocardial relaxation, left atrial pressure. Please pay attention to that, because once you understand this, it will be very easy to classify your diastolic dysfunction, and then left ventricular pressure and compliance. And last but not the least, but very important, the loading conditions of the heart. Now, I will not go into that. Now, using this information, we take transmitral flow and TDI and the pulmonary venous flow. It is divided into 4 stages. So I have condensed 5, 6 slides in one. Here is the Doppler pattern, symptoms, LSIs, and LV and diastolic pressure. As you can see, this is normal, and LSIs is normal, no symptoms, and E twice the size of A, and left ventricular and diastolic pressure normal. This is grade 1. It's not only EA reversal, but you have to have prolongation of the deceleration limb of the E. And at this stage, your LA is slightly enlarged, patient is symptomatic, and if you take LV and diastolic pressure, it's high. Then this is the most important and also the treacherous. कहा हो गया भाई इसको? The third one, देखो ये तो काम ही नहीं कर रहा तुम्हारा. ओके, हाँ ये ऊपर जा रहा है. क्या हो गया इसको? Okay, this one. You see, this is called pseudonormal. You have normal EA ratio. Pseudo ka matlab hai jhoota, but this is not normal. Have a look at the deceleration limb of this E, and this is crisp, which indicates a high left ventricular and diastolic pressure. At this stage, your patient is severely symptomatic, LA very big, and if you take left ventricular and diastolic pressure, it will be very high. Now, I always pay some attention and give more time to this one because this is one type that predicts the prognosis and it also helps you in revising your treatment. You ask your patient to do Valsalva's maneuver, and for those of you sitting here on bedside, you put your fist and epigastrium and ask the patient, is bahar nikalo? And if your LV is pliable, this will go back into grade 1. If it is not, that means poor prognosis. And the third one is the restrictive type, very poor prognosis. Once I was doing an echo and my LA jumped out of the screen, okay, very high. And this is the pulmonary vein. If I have time, we will come back to it. Okay, this was my original paper published in that. Here you can easily see the pulmonary venous flow and the correlation with the transmitral flow. Now, I was talking about M mode. For those of you and in peripheries, if you don't have expertise for this Doppler, if you see this kind of picture in M mode, which is called B dash formation, it's a sure 200% sign of elevated left ventricular and diastolic pressure. And if you increase the dose of diuretics, give a decent combination of beta blocker, AC inhibitor, and these days ARNI, there is tremendous improvement. Now, this lady, oh, bhai kya hua? You can see again Dr. Tajik here. And this lady in between is Dr. Liv Hatley, a very highly qualified lady. I was talking about loading conditions of the heart. I was at Mayo, and a young boy of 18 came. He collapsed in bathroom. So Dr. Tajik and others, they were planning to take him to cath lab. So this lady, she was visiting. She said, Dr. Tajik, why don't you take detailed history? Has it lost fluid? They took history, and the man had severe gastroenteritis 2 days before that. So this is the effect of loading condition. If there is hypovolemia, wo pattern ho jayega, hyper hua to will be pseudonorm. So that's why I've put it here. Now, tissue Doppler imaging is talking about loading condition. It was very good, that 4 stages. But what I told you about hyper and hypoglycemia, then people thought we should exclude the velocity by the flowing blood, and they started taking at the medial and lateral annulus. So far, so good. But the problem here was that this pattern was affected by the movement of your chest. And then they thought we should come to another modality, which was the strain and the strain rate imaging. You see, strain is there's a local area of deformation and contraction, so obviously it is very precise. And so heart failure with preserved ejection fraction is a big problem. And in here, there is reduction in longitudinal strain, which indicates endocardial ischemia and fibrosis, and smaller reduction in radial strain, and no change in circumferential strain, which indicates that problem is at the level of subendocardial layers. Now, the characteristic is that this is not affected by loading conditions. Now, another very important role of echo Doppler is in cardiac resynchronization. You know, for end-stage heart failure, you do these ICT implants, and this echo improves selection criteria by assessing LV dyssynchrony. And you can assess dyssynchrony by all these methods. I will show the diagrams. This is by M mode. This is by your pulse Doppler. And this is, again, color Doppler. And this is 3D. So, and then the latest, now we are using left atrial strain a lot, not only to diagnose, but as a matter of fact, to predict heart failure. And left atrial strain, it assesses LV stretching and contractility. And it reflects both functions and subtle left ventricular diastolic dysfunction. So, reduced reservoir strain is associated with increased risk of heart failure. There are three types of strain: the reservoir, conduit, and the contractility. Now every time people are talking about guidelines, European, American, and I always tell them we, the brownies, are not even included in theirs. So, why are we dying for those guidelines? Now, it is for people like us. We are in South Asia, and it has been seen that South Asians generally have a smaller heart size. So, the smaller the heart, so the left atrial size will also be small and reduce left atrium volume compared to other. So, what happens? This smaller LA, as a matter of fact, is a blessing for us. You must have seen that we have very high incidence of diabetes, hypertension, obesity, etc. But we don't see that many cases of atrial fibrillation as are seen in the West. And here is the protection. Your smaller LS size protects against atrial fibrillation by reducing the risk of re-entrant circuit formation and atrial fibrosis development. तो हर चीज़ का फायदा भी होता है. So this is one reason we don't have very high incidence of atrial fibrillation. So here I am from M mode to strain, and this was the latest picture at Cardiology Updates. I was maybe recognized for doing whatever I'm doing. So here I come to the end of my talk from M mode to strain.